Hello, everyone. Thank you all for joining and for attending the Council of State Government Justice Center's Collecting and Utilizing Data in Community Responder Programs webinar. Elizabeth, could you bring up the slideshow? Thank you. Thank you. So again, thank you so much for coming. My name is Ashton Tolles, and I'm a senior project analyst in the Behavioral Health Division at the CSG Justice Center. And today we will be hearing from speakers from the CSG Justice Center, Integral Care, and Portland Street Response on best practices for setting data metrics to capture the positive outcomes of community responder programs. This webinar is supported by Vital Strategies, and we thank them. The goal of this webinar is to show you examples of quantitative and qualitative data to support people in crisis that prioritizes, number one, connecting people experiencing behavioral health conditions and crises to care, and number two, reducing the number of people who are involved in the criminal legal system due to poverty-related issues. And so we really want to use this webinar today to help you frame your own programmatic data to encourage funding sustainability, to divert people from repeated hospital and jail system contact, and to capture the number of people who are actually receiving services and more. I would like to thank and introduce our speakers, Marissa Aguilar, Robin Burek, and Sarah Wurzburg, for coming into this space today to share their knowledge with our audience. So if you could move to the next slide. Next slide. Yes, thank you so much. So Marissa Aguilar, I will introduce her first, is the practice manager of the expanded mobile crisis outreach team at Integral Care. Since joining Integral Care 7 years ago, Marissa has, I'll just mute this person really quickly. Marissa has contributed to their mobile crisis services and crisis intervention training for first responders. Marissa has played a key role in bridging the gap between behavioral health services, emergency medical services, and criminal justice. And Marissa has presented numerous workshops, including at the 2016 and 2017 American Association of Suicidology Conference and 2019's Texas Library Association Conference. I would also ask you to please mute yourselves as you were coming in. And next, I will introduce Robin Burek, who is the program manager for Portland Street Response in Portland, Oregon. She brings over a decade of experience from both the mental health industry and local government to design and build out Portland Street Response itself. Robin oversees the team development process from recruiting to onboarding. She also develops policies and protocols, maintains the program's budget, and is responsible to find external revenue streams and support. In addition, she communicates with community stakeholders, elected officials, and media, and is in the process of getting the Portland Street Response ready for the citywide expansion next year in 2022. And lastly, I will introduce Sarah Wurzburg, who is a program director in the Behavioral Health Division here at the CSG Justice Center. She oversees technical assistance focused on behavioral health, diversion, and reentry, and serves as a lead for projects related to substance use, mental illnesses, and housing. She leads the work on the development of community responder programs, including a toolkit that we will review later that supports sites in developing non-police responses to people in crisis. If we can move to the next slide, thank you. So I want to provide a quick overview of the CSG Justice Center before moving forward. The Council of State Governments Justice Center is a national, nonpartisan nonprofit that works with communities across the country, regardless of their political affiliation, to improve their justice system processes. Next slide, please. So reviewing our goals, specifically for the Behavioral Health Division within the CSG Justice Center, we are trying to, number one, reduce incarceration rates, number two, advance health, opportunity, and equity, and number three, use data to improve safety and justice for people experiencing behavioral health conditions, substance use disorders, homelessness, and poverty. And we carry out a diverse span of work around providing broadband technical assistance through webinars such as this one, peer-to-peer learning calls, and policy guidance. I will move to the next slide, please. Community responder programs. Before we move forward, I just wanted to define what community responder programs are. Community responder programs are alternatives to law enforcement responses for people in crisis or for people who are creating social disturbances. They're led by community responders, and these can include people ranging from mental health professionals to community paramedics, to nurses, to community health workers, to peer support specialists, and other forms of social workers as well. And these are people who have experience and specialized training just to specifically help in people who are experiencing crisis, to connect them to social services, whether that be mental health care, whether that be housing, short-term or long-term, and basic needs. And the teams for community responder programs include from 2 to 4 specific community responders. And the next slide, please. So this is providing an overview of the community responder program toolkit outline. Sarah Worsberg, who will speak next, has spearheaded a digital community responder program toolkit centering on providing information, resources, and related research to support the adoption and expansion of community responder models on a national basis across the US. You can find the outline for the toolkit presented here, and the toolkit will launch on October 12th, which will include briefs, web articles, webinars, including this one, links to existing reporting, including information shared by community responder programs and site examples. The types of topics that will be covered include stakeholder collaboration, needs assessment, staffing, call triage, safety and wellness, financing, legislative strategies, and more information on data collection. So definitely be on the lookout for that event, and we encourage you to attend that on October 12th. So now I will turn it over to Sarah Worsberg to discuss data considerations for community responder programs. And as we continue throughout the webinar, please feel free to ask questions using the chat function, and we'll promise to get to them at the end. Thank you.
Thanks so much, Ashton. Next slide, please. And then thank you. Oh, go back. Okay, so as part of our work in developing the Community Responder Program Toolkit, we actually went through and reviewed a lot of information and data that was available for sites who were either planning or implementing community responder programs. And so in doing that, we basically tried to look across the different information that was publicly available to identify some common metrics that are currently used in sites across the country. And you'll hear more from 2 of the sites later, which I'm really excited about, who are doing great work in this area. And the findings here are really a summary of what programs are currently collecting. So I want to be specific about that because it's not necessarily like every metric that anyone could collect. This is just trying to look across different sites, create common themes, and share that with the people who are on the webinar. As part of the toolkit, we'll have some articles and additional information on data collection as well. So definitely keep an eye out for that in October, which is coming up pretty soon. Next slide, please. Okay, so we really tried to also think about what are some of the actual techniques that sites are using to get data collection and evaluative information. And we're seeing a lot of work within community surveys. So within the planning phase, a lot of people are doing surveys of the community to think about what kind of response team would be a best fit for their jurisdiction and to get feedback. There's also community surveys that are done potentially after an interaction to see if the community member who may have requested the community response team is satisfied with the interaction as well. So there's kind of a couple of different ways we're seeing that. A lot of sites are doing interviews with community members in part of the planning phase, but often also in part of the implementation phase to really continuously get feedback from the community to make sure that the responder program is meeting the community needs. There's also often interviews with program staff or stakeholders. So that could be state and local legislative officials. It could be members of police departments or fire and emergency medical services who often would be a typical 911, would be typically responding to 911 to hear more about what they have found helpful in interactions for people with behavioral health crises or who are being involved in the process due to social disturbances. A lot of sites are doing focus groups, roundtables, and qualitative methods to really get additional feedback from the community and in the planning process, but hopefully on an ongoing way moving forward. There's a number of sites who have really cool data dashboards. You'll see one later from one of our speakers here. So there's often in some of these sites real-time data available or near real-time data available where you can actually see what the community responder teams are doing. And then, of course, the evaluations are a big piece of this, and really any new program that's starting, evaluations tend to be a big piece of that. So there are some evaluations within a pilot phase when people are starting out. So let's say the first 6 months of a program. And then there are sites who are working on longer term evaluations to be able to show longer term outcomes for these programs. Next slide, please. So when we're looking at data collection and review of data, a big part of this to begin with when sites are in the planning phase is related to needs assessment and asset mapping. So really seeking more information on what the community needs are. And the first step of this is really looking often at police, fire, and emergency medical service data, since they are typical responders to 911 calls for service, to try to see what types of calls might be appropriate for community responder teams. We'll talk a bit about call triage data next as well. There's also a lot of needs assessment work going around community outreach and engagement. We discussed that a little bit further in our last webinar on community engagement too, so would point you to that, which will be available on the toolkit and the website moving forward. And then asset mapping. So when we're saying asset mapping, it's really looking at what services are available in the community. So community response teams are able to do an immediate response, but often they need to make referrals for further services. So knowing what types of services are available in the community already, whether it be for housing, mental health, substance use disorders, is a really important feature, because the community response team isn't going to solve all of the needs of the community, but they may also be able to help identify some of the gaps that they might be able to support as part of the processes. Next slide, please. So this is, again, an aggregate of metrics across some of the different areas. And for the call triage work, a lot of this call triage work has been done for the toolkit by Amos Irwin from Law Enforcement Action Partner and Betsy Pearl from Center for American Progress. So just want to acknowledge their leadership in this area and that they're key thought partners. So when we're thinking about this, I think there's different ways of breaking this down. So there's information on the call. So the calls actually received through 911. There's responses, so the dispatch and who is dispatched to the scene for these calls. There's encounters, so engagement with the person or the client. And then there's the referral, so if the person was given a referral to additional services. So I think those are kind of the key areas in which, we'll discuss a little bit. But when we're looking at the call triage and response data, it's really thinking about what calls are appropriate for community response team, the total number of responses that were initiated, the types and numbers of incidences responded to. So what types of calls have actually been working for the community response team? What's the response time? What are the numbers of unique people served? So there could be someone who has multiple encounters with community response teams, so having that information as well. And then the percentage of calls that are diverted away from a police or a police response is often a key piece of this as well. Next slide, please. So just some additional data metrics that we saw sites collecting from the information we were able to review. So there is the number of people engaged in services. So like if you make a referral, are they able to engage? What type and number of crises are responded to? the number of people who decline services or referrals is a really important piece. So most of these programs, are voluntary. So if the person declined the interaction, that's a big piece of it. And if there's information on why that can be collected, that's also helpful. The rates of referrals to other services, the number of referrals completed, and really just trying to see if the people actually initiated in whatever the referral is. So let's say the person was referred to a homeless service provider. Did they actually engage with that provider? Did they actually go to that provider is an important question that ideally we'd love for sites to be able to answer. Next slide, please. There's also a series of questions that often have specific fields that have further breakdowns that we just wanted to point out. So was the individual transported to another location? Where were the needs of the individual met? Was police backup required? What type of interaction required police backup is an important thing. And did the individuals require additional help or emergency services? So was part of the outcome dropping them off at an emergency room, for example? Next slide, please. And then the other pieces, I think, are larger things that you would typically think of that you might want to collect. So the percentage of calls that are diverted from the emergency services, if people are able to be diverted away from hospitals or jails, so decreasing further interaction with the criminal legal system or with emergency rooms as well. Post-contact client outcomes. So this is something that's very hard to track because you have to coordinate with different providers often to get that information. But if there is information available, that's really helpful. Client demographics, if applicable. And then some sites are actually trying to break down some cost benefit information, which could be useful to them in the long run or for long-term sustainability. The other piece that I just wanted to mention is that one of our colleagues, Rachel Bromberg from Reach Out Recovery Network, has been thinking a lot about metrics related to safety, and there will be a brief in the toolkit to talk about tracking safety, and then we'll have information on safety and also staff wellness as a part of this. But there haven't been very many safety incidences for community response programs in general, but it is a common question from policymakers in terms of the safety of the community responders as well as the person who is receiving the response. So really thinking about the rates of requests for police backup, trying to separate the calls down for perceptions of danger, risk, violence, and other things, tracking staff injuries if they're applicable, and why the staff was injured, really thinking about if there's like more information to break that down. So if a staff member stepped on a needle while they were walking down the street, or if there was an injury related to an interaction with someone at the scene as well. So for the evaluations piece, as we said, there's a number of sites who have some evaluations that may be available, a subset of them, but a lot of sites have detailed in part of their plans of their expansion of community responder programs that they'll be doing evaluations. So we're definitely trying to keep an eye out for that. And I think we can also look to other literature on pre-arrest diversion, mobile crisis, street outreach, and violence prevention to support some of the needs for community response programs. But we hope sites will continue to really think more comprehensively about the data and continue to do evaluation work as well.
Thank you so much for sharing, Sarah. That was all just fruitful information. We'll be sure to share it with you all afterwards when we share the slide deck. So next, we will have Marissa Aguilar from Integral Care in Austin, Texas.
Hello, everybody. My name is Marissa. I'm the manager of the Expanded Mobile Crisis Outreach Team. I'd just like to start off by giving you some information about our program, historical operations, where we were at, and then kind of bring you up to where we're at to date. I think it's relevant as I'll talk about the data specific to where we started our project, where we're at to date, and how the data really assisted with sustainability of our project when our funding sources changed, and then also continuation of what that would look like. So I work for Integral Care, which is the local mental health authority of Travis County and the local intellectual and developmental disability authority of Travis County in Austin, Texas. I feel very fortunate to be in Austin in that we have a pretty robust MCOT team that are deployed out through various intercepts within our crisis continuum. Our first MCOT team started in 2006, and they receive all of their referrals from our 24/7 crisis hotline. In 2013, we did a analysis of crisis calls that were coming in through our hotline, the number of calls that went out where MCOT responded in the community, and we compared that to Austin Police Department and the number of referrals they went out to that involved a mental health component. And what we saw was that calls going in through the 911 system far exceeded what we were seeing at our hotline 472 help. And I think it was very evident that, individuals are calling 911 as opposed to 472 help because they don't know the resource, or they revert back to calling 911 when they're in a state of crisis, but they do know the crisis hotline number. So in 2013, we expanded our MCOT team through funding from the 1115 Medicaid Waiver Project. And that allowed us an opportunity to train first responders in recognizing signs and symptoms of mental health crisis. And they had the ability then to get on their radios and request an EMCOT team come out into the community where that individual was having a crisis. Some of the data that we looked at when we started this project, and we really focused on the overuse and misuse of very restrictive settings that included emergency room admissions, transportation to ERs, inpatient hospitalizations, involuntary commitments, and incarceration. Included the number of unduplicated and duplicated individuals that we served. We also reported on the number of referrals received from each first responder partner. So how many were we getting from law enforcement? How many were we getting from EMS? And then how many were we getting from criminal justice systems? For outcome data, it was really important for us to really show the benefits of our program. So the three primary outcome data that we started off with reporting on, that we continue to report on to date, are how many times was EMCOT called out to, and were we able to divert from arrest? Were we able to divert from a peace officer's emergency detention, which is an involuntary commitment? And how many calls were we able to divert from ER transport or an ER admission when someone was experiencing a crisis? So the success of the data that we were able to show really helped when in 2018, funding shifted through the waiver, and it was no longer focused on metrics related to crisis response, and showing our community that in order to have and successfully meet the needs of individuals in crisis, utilizing all of those output and outcome measures assisted with providing funding to sustain our project through the city of Austin and the county as well. So we were able to continue that service when that original funding shifted. And where we are most recently is in 2019, the city of Austin provided additional funding so that we could integrate into the 911 call center. So we still have the same models that I was talking about. We still have an MCOT team who goes out through referrals received from our hotline. We still have the ability for first responders to arrive on scene, determine there's a mental health crisis, and then request an EMCOT clinician out to provide immediate assessment. But now with the integration into the 911 call center, we have clinicians more upstream in that process where we're able to focus on ensuring that we're providing interventions and diversion when someone has called 911, but there's not a public safety issue and there's not an imminent risk of harm to that person or the community. Those calls are now being transferred over to our clinicians on the floor where we take over those calls and we determine what is the best outcome for that individual. I'll share information about what our different outcomes are related to and the data that has helped with this project. In 2019, we were able to secure funding for 6.5 employees to start that integration into the 911 call center. And it was really through the data that we were able to show a need for additional personnel. And we have since in this current fiscal year utilized the data from that initial first year pilot to expand to include several more clinicians, and we are now 24/7. Another cool thing that we've done in our community, before I move on to the specifics about the data, is just want to highlight that in February of this year, we added a fourth option when someone calls 911. So the call script now reads, Austin 911, are you calling for police, fire, EMS, or mental health services? We are, according to the Meadows Mental Health Policy Institute, the first city in the nation to add this as a fourth option. And we did see that there was a huge increase in calls transferred to our clinicians on the floor because people were able to self-identify at that time, which was a game changer for us and our community, but also we saw it reflect in the data that we were capturing as well. Next slide, please. So specifically for the data that we're collecting in the 911 call center is we're looking at the call types related to what the first responders, so the call takers, are coding. And we're also looking at how our clinicians are coding the call types to see if there's any discrepancies or ways in which we can further train the call takers. We have ongoing training so that they're able to recognize and identify mental health symptoms or crisis so that they can appropriately route those calls to us. We're looking at primary reason for the call. So if we identify that we're getting a lot of calls where they're check welfare and it might be related to someone maybe experiencing symptoms like psychosis, but not a lot of calls related to suicidal ideation, that gives us an opportunity to open up that conversation about maybe some more training that's needed on identifying or assisting the call takers and transferring those calls over to us. We're looking at the average time we're on calls. That's about 15 to 20 minutes. Our purpose is really to do a screening and triage of the most appropriate resource, although it varies depending on what we're being asked to do as far as emotional supportive de-escalation. And then the call length. So that's really important information for our funders, our community as well, but it also helps with programming, how we're staffing our clinicians, are we at to scale, and what do we need to do to ensure that we have the capacity to meet the needs of the calls coming in. We're looking at our initial outcomes of the calls as well. Some of those outcomes include emotional support and de-escalation. A lot of times what we're seeing is that the individual that we're talking to is someone who's already connected with our services. So not only do we have access to first responder systems and technology, but we're also looking at our electronic health record. So if we identify someone is already accessing services, we're going to refer them to their ongoing treatment team if there's not a need for a crisis team to go out immediately for assessment. We also have what we internally call a callback roster, where we're providing resources for individuals that are safe to remain in the community. And then we might call them back in a few hours or the next day to make sure they've connected with resources, provide telephonic support, and ensure that we don't have to deploy a team out to go provide a face-to-face intervention. We also have the ability to dispatch our own team to go out to do a face-to-face clinical intervention, because we're diverting police response at the initial onset of that call. We have a two-person clinical team that is going out into the field to provide that initial assessment. More recently, what we've added is a clinical team that is comprised of an EMCOT clinician as well as a community health paramedic that are teaming up to go out into the community to start not just a clinical mental health assessment, but identified medical necessity and intervention as well. And then, of course, if we do identify there is a need for public safety or medical emergency, we have the ability to transfer back to our first responder partners. So that that is typically happening 16 to 18% of the time. We have a pretty consistent 80+ percentage of diverting police response completely once the call gets transferred over to us. And then we further break that down. We're looking at why we're transferring back to police. About half the time, it's because there's imminent risk of harm. The individual is unable to safety plan. We're also tracking when our response teams are unavailable, because that also gives us information about are we to scale, and why are we sending that back to police, which is important for us to provide to our funders in our community. And then the other half is for individuals where we've offered our services, but they are still requesting police response. And those get transferred back because we are voluntary services, and we don't want to block that person's request for a first responder, even if we identify there's not a public safety issue. Finally, what I'll talk about for this slide is demographic information. I think that's very important for just figuring out the populations that we're serving, how to be culturally responsive in our telephonic assessments as well as our face-to-face assessments. So we're collecting information on the phone if possible and if appropriate, race and ethnicity, gender, and languages spoken. We're also collecting demographic information related to where they're located in the community. If that's able to, if we're able to obtain that information on the phone, that's something that we're striving to gather. If not, if a team is deployed out to do a face-to-face response, we're gathering that information with that person during that initial assessment, again, if it's appropriate to do so at that time. Next slide, please. One thing that we did prior to our second expansion of the call center specific project, during the first year, our agency did a cost analysis of program impact. And it really looked at what the cost savings would be for the integration into the 911 call center. It specifically looked at the cost related to Austin Police Department's mental health response, where on average they have at least 2 officers assigned and responding to a mental health call, the average time they're on scene, and then they put that cost per unit. We looked at the typical response involving an ambulance or fire truck and the transport related to that. An emergency detention is an involuntary commitment. So we looked at those types of calls. And then a psychiatric hospitalization admission. So for the first 8 months of our project, with the amount of calls that we took in looking at all of these different components and cost related to more restrictive settings and first responder response in a mental health crisis, we saw that there was about $1 million in cost savings that we helped within that first 8 months. The projection that you see on the screen for a 12-month scale was what it would look like if we moved through this current fiscal year and we attained our goal of what we were projecting, which was 5,135 calls. If we met that with this methodology, we would be looking at cost savings of $12 million for our community. So this was provided to our city council, who is our primary funder of the call center integration project. I also do want to just say that while I think the cost analysis as well as the output and outcome measures are really important and data points that we've been able to report on either quarterly, annually, or when we're coming up for funding. We also always include a personal story of how we've really provided an impact to the individuals that we've served, whether that be at the call center or when one of our MCOT teams is responding out in the community. We find that pairing the data, the numbers, the values, the monetary benefit, as well as the personal aspect of the impact that it has for someone in crisis is really valuable, and it really touches a lot of people. I think we can all agree that if we've not personally been impacted in our lives by a mental health crisis, we know a loved one, a family member, a friend who has. And so I think that's something that anybody can relate to and really shows the benefit of these crisis responder programs and the value that it has for the community. I believe that's it for my section. So I'm going to go ahead and hand it back over.
Thank you for sharing, Marissa. That was just definitely just well put, specifically on the narratives. And we'll touch on that later when we talk about both quantitative and qualitative data. Robin, I will give it to you to take it away.
Well, thank you so much. My name is Robin Burrick. I am the program manager for Portland True Response, and I'm thrilled to be here with you. If you'll flip to the next slide, that'd be great. So we created a data dashboard. One of the things that we did at the outset of designing this program was meet with various stakeholder groups. And we asked them, how can we display transparency, and what is it that, how can we relay information to you, and what is it that you would want to know? And so in response to the feedback that we received, we created this dashboard. I actually put this together. I'm not a whiz at data by any means. So hopefully there's some grace here. We actually just hired our data analyst that's going to be starting next week, and we'll be jazzing it up. But I really opted more for the straight numbers rather than visual graphics, with the intent of developing that later. I just really wanted to show the numbers as best as possible. And so what you see on this slide right here is the first page of our dashboard. And of course, what everybody wants to know is how many calls are you going on? And for us, we're in about 5 square miles. We're still in our pilot phase. In fact, today is our 7 months since starting our pilot. So we've been on 25 calls so far in September, as you can see, just over 424 as of this week. And then other data metrics that people wanted to know was, how long does it take us to get out to the scene? How long does it take us when we are on the scene? And we've really been playing around whether to do average or this 90th percentile. And if you looked at our averages would actually be actually for the response time, instead of 21 minutes, it's actually 12 minutes, which is pretty good. But we chose the 90th percentile because it kind of puts those outliers out, and it looks at really what is the chunk of the responses that we're going to, what's going to be the predictable norm. And then to the right, you see measure 3. There's the percentages of calls that involve some kind of co-response. And you heard my colleague today talk about some of that as well. For us with police, we are an alternative to police. So this is probably one of the most important metrics that community members want to know. And so on the bottom there, I have the note that the majority of the calls that involve police co-response were actually police requesting our assistance. Any ones where you see like AMR, PPB, psychiatric hold, that involves an involuntary hold, which we don't have the capability of doing involuntary holds. It requires police and the ambulance to come and do that. So this first page of the dashboard is really set to sort of answer some of those questions about our performance metrics. How many calls are we going on? How long are we on scene? How long does it take us to get there? And who are we working with? The majority of the calls that we go on, as you can see, 90% don't involve any co-response whatsoever. Next slide. Okay, so it's a little tiny to see here, but this second page of our dashboard was really intended to address more of the outcomes and who are we serving and what are we seeing when we're out in the field. So at the top, measure 4 is the needs assessed by category. And I will say, because we're in the pilot, we're still always looking at this information and determining, okay, are we asking the right question and how are we asking it to capture this information? And so it's been challenging as you update your dashboard, because you're also updating your charting system and how you're capturing this information. And that can be really hard sometimes as you're still evolving your program. You're going to have some gaps and some inconsistencies as well. So for instance, you might have what we call a bunch of nulls, where it means there's no data entered because maybe for the first 4 months, you weren't even tracking that information. And so it looks like your data might be a little bit skewed. So that's just something important to remember as you are developing what the data is that you're reporting on. But measure 4, so the needs is addressed by category. And this is one of those categories that has evolved. Since we started collecting data, we were collecting drug and alcohol use, and then we decided to change that to suspected drug and alcohol use, because sometimes it's difficult to really determine. The same thing with mental health. In our charting system, we have suspected mental health. So sometimes when you arrive and somebody is in psychosis, it can be difficult sometimes to determine whether that is mental health or if that is a substance use induced. And then the other thing that we added, and this has evolved, is trying to track chronic health needs as well as acute health needs. And then unmet basic needs was the other metric that we decided we needed to do a better job of tracking. And what we were starting to find was this correlation between the mental health, substance use, and unmet basic needs. It's important to note too, for us, we are only going to calls that are outside. We don't go into residences just yet, though that is our intent to eventually do that. So the majority of the individuals that we actually respond to, they're actually being called on. They're not calling for themselves. And I think that's another important metric to consider as you're looking to track information. Along with that, a pretty sizable portion of our population are houseless. And when we track the individuals experiencing houselessness, what we try to track is, are they living in a tent, in a camp? Are they in a vehicle? Are they in a shelter? Are they couch surfing? And trying just to get more information and detail around their condition might be able to assist. Patient outcomes measure 5 has been one of the most popular metrics that we've had in terms of feedback that we've received. The public have really appreciated the fact that we put our outcomes out there. It shows a level of transparency. And I think what a lot of people are actually really fascinated about when they look at this is how many people what percentage of people we actually don't make contact with. And Sarah was alluding to that in her presentation today too. That's one of the metrics that a lot of programs are tracking. And that's actually, it's an important feature because there's two causes really, right? So either we get canceled on the way and we aren't even able to like complete trying to get to the call, or we get there and the person declines our services, and we are a voluntary program. So it's important to track that as well. And the other thing is that we might not find the person. And so when you think about response reliability for police or fire and taking these calls away from them, you're actually saving those resources from having to go out and try to track down somebody. And so that's actually a win-win for all the systems. Though, of course, we would prefer to be able to locate the individual and address the call, but we have at least saved the other first responders from having to do that for these non-emergency, lower acuity type calls that are coming into 911. And then we also track the referrals. So we're trying to track what kind of the categories that we're referring into. We dispatch our firefighter, paramedic, and our licensed clinical social worker to the calls directly. And then when they arrive on scene, if they determine that somebody needs to get connected to referrals or resources, we actually call our community health workers to the scene at that moment to make a connection. And we do that primarily because we are working with such a large population of individuals experiencing houselessness that it can be difficult to connect with them later on down the road. So having somebody come to the scene is really important, and making that connection right then and there. And then our community health workers can work with someone as long as they need to get them connected. And we track all of that information. So our community health workers actually have a separate charting system from our first response team. They have a community health module where it allows them to do follow-up and track the progress and the goals of that individual. We're also tracking how long does it take to get somebody referred into a program. If they get denied to that referral, what was the barrier to getting them into that service? And part of the reason that we're doing that is that the state of Oregon is ranked 48th in the nation in terms of mental health and substance use infrastructure and treatment resources available. And we really, really want to understand where are the gaps in the system. We want to use this data to better inform our politicians, our elected officials on where they can put their money to help build up this infrastructure, because at the end of the day, it's going to impact our program as well. And then we also track transported. So right now we are still developing our vans, and our vans will have transport capacity, but we don't have that right this minute. So we do arrange ride share taxis. We give bus tokens, and so we track all of that information as well. Next slide. And then you can see this is our pilot area. So we want to show individuals where the majority of our calls are coming from or going to. And this is our heat map. And it's been really fascinating. What I'm really interested to see is as we expand citywide, how this share will go across the entire city and how it will line up with both police and fire related calls traditionally, if there's overlap. And of course, you could also pull some of the demographics around like the census data, right? So housing income, median housing income, demographics, all of that, and overlay these things. And that will provide a lot of wealth of information for, I think, everyone involved. Next. So one of the things that Sarah had talked about a little bit was program evaluation and how do you collect data for that. And so we have contracted with Portland State University to do a lot of surveys and focus groups for us. But in terms of how we collect, customer feedback from our services, that's been more challenging because when you're in the middle of a crisis, you don't want to get a customer feedback card at the end of the day, right? It's a little tacky. So we are actually really interested in looking at social media. Social media gives us a wealth of information. for program evaluation. And simultaneously, it also gives us an opportunity to share information as well about our services. So it's a two-way street. And what you see here is these are stories of success stories that we've had, of course, all anonymous. We're not identifying any individuals, not gender or nothing. And we just tell our story of some of the work that our community health workers are doing. These are a few pictures of individuals this is our community health worker that works on our team. And these stories are about individuals that we got housed who'd been chronically houseless. So this is a really great opportunity too. When you think about data, think about it in the qualitative format, not just the quantitative numbers that you can share. What are the stories that you can tell as well? And then what is the information that you can mine from the comments and the feedback and the shares and the tweets and all of that you're going to get from your citizens? By and large, I would say the majority right now of our citizen feedback has been really positive from social media. We do have the occasional trolls, of course. I think everybody's going to experience that. But by and large, it's pretty telling of the acceptance and feedback that we're getting from our community is positive. So I will hand it over. That's the end of my presentation.
Thank you, Robin, for sharing all of that detailed information, specifically as it relates to not only just measuring the positive outcomes of community responder programs, but also actually truly identifying the actual gaps that you perceive in terms of service delivery so as to encourage more funding sustainability. So I just learned something there. So thank you for sharing. So next, I'm going to get into a panel dialogue where I'll pose a few questions to the speakers, and you all are welcome to answer in 1 to 2 minutes or so. I want to make sure that we also can get to the audience questions later in the Q&A after that. So I will pose the first question. The first question will be, Marissa, I will pose this to you. What are a few key data metrics that have been useful for your community responder program specifically? I know that there are themes that Sarah has identified across programs, but I just wanted to have that reviewed again.
Sure. Some of the outcome measures that are very important for our community are the three that I talked about: the diversion from incarceration, the diversion from peace officers emergency detention, and then an ER admission. Specifically at the 911 call center, the biggest outcome that we're looking at is the percentage of calls that we divert from police response. When we look at the outcomes related to clinical operations, we're looking at the linkage that we have to ongoing services. So what percent of our clients do we connect to an ongoing service before we step out? And I think that that's really important because part of the MCOT model is really to ensure that there's that linkage to reduce any future crisis episodes from occurring. And then, everyone's always interested in how many people you're serving, and then how many calls are getting transferred. So I think those are all good outcome and output data that we're looking at. And a lot of it, at least for the output data, because we rely heavily on first responder systems to provide us with that referral, I think it's just so crucial to build those relationships with our first responder partners. If they don't buy into our services or we're not working collaboratively, out in the community, then we won't get referrals to help individuals in crisis. So I just want to put that out there. I know we're focused on data, but so much of what we do is rely on these systems to refer individuals in crisis. And so I think that it's really important to build these relationships and trust. And I use the data to help show them, how it is impacting people and how it does help reduce the burden of responding to these calls that they're not expert in, and we can take over.
definitely appreciate that in terms of using data to actually build relationships. So not just viewing the number of people served as numbers, but actually using that in order to encourage stronger referral processes. And I wanted to welcome Robin and Sarah to pose any answers to that question around data metrics that are really useful and helpful and seem to resonate with your audiences. And if you don't have responses, we can move on to the next question.
We have 3 outcome goals that we set out. So one is to reduce the number of calls that police respond to where no crime is being committed. Another is to reduce the number of calls being transported to the emergency department where pre-hospital care could be administered. And then the third is to reduce the number of calls going to police and fire. But what we realize is that third metric actually needs to be tweaked a little bit. So instead of just saying we're going to reduce the total calls that are going to police and fire, we actually want to revise that to say the total number of mental health related or behavioral health related calls that have been going to police or fire. So I think those are our 3 metrics that have really sort of driven us forward. And of course, there's lots of metrics that you can measure, and I think they're important to measure. But I would really choose what are the 3 things that you're hearing the most from the community to what they care about.
Yeah, and I think what Robin is saying in terms of their identification of a couple of key metrics to begin with, Marissa also mentioned that as well, is a lot of programs in their planning phase and in development of their plan are outlining 3 to 5 metrics as like a focus area. And I think that, makes a lot of sense to make sure that it aligns with the community as well as potential funding stakeholders. So city, county councils, which often are the ones who are funding these things. So I think that definitely, makes sense as a plan. And then just re-elevating some of the safety metrics because those aren't being collected across sites, but it is a common question from stakeholders, particularly elected officials. So if you're starting a program, really try to track if there are safety issues on the scene because you'll get asked that a lot from what we hear around the country. So just making sure that people consider some of those questions that even if it's the answer 0, just having the data to say that it's 0 is really important in a lot of cases.
Thank you all for those answers. I will move on to the next question. The next question will be, so in terms of the amount of communication for programs to engage in cross-agency or collaborative data information sharing. So whether you're sharing that with the call center or with police or EMS and fire or other providers in the area, just wondering what is the appropriate amount of communication to engage in regarding that when you're thinking about information sharing specifically around your data?
I can start with that. I have regular check-ins with various stakeholders. And so think about data sharing both verbally and non-verbally, right? Through maybe infographics. So one of the things that we learned when we met with police, there's over 700 police officers. There's no way we can sit down with all 700 police officers and, share this information. And when we talk to leadership and we've asked the question, how do we get information to them? What's the best way to do it? Sending an email is not the best way. They're not going to read it. What they informed us was having a postcard. So we go to their roll calls in the morning, and then we have a postcard that they can take with some really quick things about our program that they can take away with them and our contact information on it. And we've gotten really positive feedback around that. For elected officials, what we come to realize is that like 1 or 2 quick slides and setting up a presentation with them to provide them updates has been really helpful. For a while there, we were even sending out weekly updates with success stories and little quick tips about our program as well. And that was good. It was very laborious and for us to try to put those sort of newsletters together on a weekly basis. And we just decided the best thing to do would be to set up a biweekly phone call. And I create a lot of infographics for them. So during that call, I'm usually pulling up infographics, and those are really well received. And then we have the dashboard, and I've come to learn that some elected officials and some community members really like the dashboard, and others don't really pay much attention to it. The other thing I've also come to learn is that our 911 call center has their own dashboard about our calls, which I didn't even know was out there, and their data doesn't always align with our data. So it's important too that we think about who's got data and information about our program out there, and are we communicating with them, and are we aligning with them to make sure we're telling the same story. So I'll let the others talk. I'll stop there.
I'll just add on to what Robin was saying. Our call center keeps different metrics and measures that they report on as well. And so I think, and oftentimes we're doing collaborative reporting back to city or community groups that have requested us. So really ensuring that when we're providing the data, we're also giving the methodology and what that exactly means, so that there's no assumptions for people during that. I have found that as well. When we started, I think it just varies as far as how often you're communicating based on where you're at in implementation. When we first started integration into the 911 call center, my counterpart, Lieutenant Murphy at the call center, he and I, for about the first 3 weeks, talked every day. And we were talking about the call types, what data he was showing about calls transferred, what we were collecting, where the discrepancies were, so that we didn't have to go back 2 months later and figure out what that looked like. And just wanted to ensure that we got everything done as quickly as possible, and then just getting a feel for our team members and how they were doing, how comfortable and confident that they were. I would say where we're at a year and a half later is he and I, have a good relationship to where we don't have standing meetings, but we when anything comes up, we're constantly talking with one another. We actually, an hour before this meeting started, we're talking about data. He called me about a data point that he was being requested on. So it's gonna come up, and I think it's whatever's gonna work for your community, the people that are requesting that information, and what's going to really highlight the success of that project.
Are there any other speakers that want to respond to that question specifically? If not, I'll move on to our final question before we go into Q&A. Okay, so I want to ask, lastly, do you have any tips or advice specifically for community responder programs that are trying to get off of the ground and are in the beginning stages of building out their data collection strategy? If you could go back to the point where you were building out your own data collection strategy, what do you wish you could be able to tell your former self?
I'll start this one. I think where I would have started was asking the community, specifically our community advocates, what information they were interested in knowing. So a lot of the outcome and output measures were driven by our funders, so the city of Austin. And what we have found is that that's really important information for them for, sustainability and seeing where their money is going to, but that's not necessarily the same data elements that our community is looking at and wanting to know. So I probably would have, if going back, would have wanted to go and survey or build focus groups to figure out what are some key data points that people were interested in. I also think that having a good data system and program, if you have monies to do that or build that into the grant or whatever you're getting for your funding sources, is crucial in order for you to report back, and also for any sustainability of the project if you're only getting short-term funding. I think we have a really good, robust data system. We have a data team for our agency, but we don't have a dashboard that gets uploaded. So a lot of this is still, things that we're doing manually through Microsoft. We're doing it through Power BI. So I would say if you have the monies to request that or ask that, to get that at the beginning, because it just makes it so much easier when you're constantly getting requests about the data, and it evolves as you evolve your program.
Well, we did go to the community and we did ask those questions. So we have that at least. But I would say what we didn't have is we didn't have a data analyst. And you kind of have to be scrappy in the beginning stages anyways. Everybody's doing a little bit of everything. But gosh, given the amount of attention that your program is probably going to get by the community, by elected officials, by the media, you really need to have somebody, I think, dedicated to being able to go through that data and really set you up for success from the beginning. And so if I could go over again, I would have requested a dedicated data analyst from the start. I don't know that I would have gotten it, but I would have requested it. And I would say the only other thing I would maybe change to is I would probably sit down more frequently at the start with my team and look at the dashboard that we had going at the start, because I think you can catch a lot of reporting errors and charting inconsistencies. And, when we think about charting data, you need clean data, in order for it to be reliable. And so sometimes when you sit down with the team, you get a lot of good insight, like, oh, I was charting an incident outcome this way, and you've been charting it that way. It's really important. Or how are you determining, is everybody determining what a mental health situation looks like, or a substance use situation, like really defining those types of measures so that you can create consistency in your reporting outcomes as well. So that would be my two suggestions.
Yeah, I think the other thing just to remember with these programs is you're talking about multi-system data. So, Marissa is from the provider perspective. Robin is from, a fire department. Some of these are located in police department or non-health care based agencies. So the type of data that you have access to internally through maybe a case management system versus what you need to get from the call center, there's a lot of different aspects to this. So I think when you're thinking about the data, you really want to break it down by the type of data you need on which topic. So for your call triage processes, what type of data do you actually need? For the response team, depending on the agency they're located in, different data is available. So if you're a healthcare provider, you might have certain type of data that you wouldn't if you were located in a police department. So I think it's important to actually break down based upon your key stakeholders what data is expected from each of them and be very clear on that up front. And then who's responsible for aggregating that data? Often it's like the program manager ends up being the person who's doing that, but just like being really clear from the outset, like what data is needed from each data source, and just acknowledging that the community responder team itself maybe won't have all the data. If you're trying to track referrals, there may have to be follow-up. If you refer to, let's say, your community mental health center, they might need to give you information on whether that person ever went to those services. So I think a lot of it is actually thinking about how to break it down and thinking about, based upon your agency and where you sit, if you're leading this effort, what that looks like. Or in some areas, the city or county government is really focused on aggregating the data, so they may also have a different perspective. So I do think it's just important to acknowledge, depending on the way you're building your community responder program, you may have access to different data, And then you want to get input from the community, particularly the community who's most impacted, Black, Indigenous, people of color, communities that have disproportionate police contact and justice system contact, and also state and local elected officials, because you want long-term sustainability. You're going to have to make sure you're getting data that they would want to see to be able to say, yes, we'll give X amount of dollars to be able to continue funding or to expand this to 24 hours.
Yes, thank you, Sarah, for sharing, and thank you to Robin and Marissa as well. I think that it's really helpful to, summarize that in that way, Sarah, mainly because there isn't really like a one size fits all approach when it comes to data collection. It largely does depend on your jurisdiction, but we do hope that from today, you're able to take some key aspects of whatever visualization you were able to see in the slide deck or whatever answers that have been provided thus far to really enhance your own data collection. And I also want to open up, just absolutely muted myself. But yes, I also want to open up to Q&A for audience members, for you all to ask questions. And I've seen that there have been some in the chat. And so I'm going to pose the first one. Is there an estimate of what proportion of the diverted calls might have resulted in an emergency room or inpatient psych admission? So the question is there an estimate of what amount of diverted calls might come from emergency room or inpatient psych admission? Also wondering if the cost will offset, or the cost offset will be adjusted to reflect estimated costs for care, since not all responses would result in admission to emergency departments. So I think to summarize this question, it's really just looking at how to specifically estimate the costs. I'm actually having a trouble looking at this question. Sarah, do you see the question within the chat that I'm referencing? Okay.
Yeah, so I think, Marissa or Robin, do you have a sense for this in your community at all? Or is the question a bit too cumbersome right now?
So I see it on the chat. I think it's in reference to the cost analysis I shared. So yes, that's correct. It's looking at the max cost avoidance. We went through the assumption of anybody who receives a first responder response, whether that be emergency services or police, could potentially go to one of those restrictive settings. So it could potentially lead to an ER transport, whether it be because of medical necessity or because the person is requesting ER, even if that's not the most appropriate place. And then on the law enforcement side, just depending on what that individual says, without, the officer necessarily having the appropriate training to determine, is an involuntary commitment appropriate? We went with the assumption that anytime there's an interaction, it could lead to the most restrictive setting and cost for that individual. However, we are starting to look at breaking that down and really asking, first responders to track, and also when our team is involved, is this person wanting an ER transport or admission, or is they just didn't know the resource? Vice versa with police. Was there a criminal charge pending? Or was this someone you went out to and there was no diversion needed for incarceration? So would this have even resulted in incarceration? So we're starting to gather that information to reflect an adjustment. We don't have that data set yet, but we're starting to collect that data.
I'd just like to tag on to that. Prevention is really hard to measure. It's how do you know that you prevented someone from getting arrested? How do you know that you prevented somebody from going to the ER? And we've tackled that in one way, and we're looking at refining it in another way. So the way that we've started it is knowing, okay, this percentage of this call type that was traditionally going to police or fire resulted in an emergency transport. So that's the baseline. So if we're taking this call type away, what is then the percentage that end up transported or arrested, if you want to use that metric, compared to what historically has happened with call responses, first response to that call type. That's one way of going about it. The other way that we've been talking about lately is actually creating a specific question. So for instance, I was out in the field and I went on a call where somebody requested an ambulance to go to the ER. We checked their vitals. They were doing fine. We actually had somebody, a passerby that worked with us that knew that individual, was able to provide some history that this person likes to go to the ER a lot, requests it quite frequently, and usually nothing is wrong and they end up just getting moved along. And so for us, it really made us think, should we create a button or something within our charting system, a customizable question that we could ask, like, are you certain that you diverted this call from the emergency department? Yes or no? And then you could add some narrative if you wanted to it. The other way you can capture that is just in your narrative. So when you're documenting your case notes, you could actually document that this person requested an ER, you checked their vitals, they were doing fine, you brainstormed other alternatives and were able to divert them away from the emergency department. So there's different ways that you can go about it, both from the baseline and historical data that you might have, but then also maybe thinking about how you can capture that in your own charting system. But prevention's hard. It's not going to be perfect science.
Thank you for those responses and also for covering me in regards to the phrasing of the question. So I also want to pose the next question from Denise Barnes. She's asking what funding sources were used for the initial grant and subsequent grants to obtain 24/7 staffing. And then also, were any community resources enhanced based on your referrals for mental health services?
For Austin, all of our funding for the integration to the 911 call center came from the city of Austin. And then to expand us 24/7 was also city of Austin. We're currently in the process of looking for the budget for the upcoming year to add our county and have a clinician available for diversion at the 911 call center for our county call takers. But right now we're 100% city of Austin funded 24/7. We did in this last fiscal year receive additional funding to add clinicians to partner with the community health paramedics to be available as a response team 24/7. As far as just other resources and expansion efforts in that way for crisis receiving centers, different, opportunities for outpatient services, beds at inpatient facilities, no. None of those services were expanded to help support this integration, although I do think it's a really good question, especially with 988 that we'll be seeing in the upcoming year. I believe that our crisis continuum, the funding needs to be placed throughout that whole continuum in order to support efforts of diversion upstream. I think it would not be appropriate to front load the call center integration or MCOT response teams and then not have avenues for MCOT to provide services or referrals. And that's not just mental health, it's substance use. It's a lot of our is housing needs as well, basic needs. So I think having monies go to our whole crisis continuum and would be beneficial, especially as we see movement towards 988 also happening.
Yeah, the other thing I would add in terms of funding is that there's a lot of federal dollars out there that can be utilized right now through the American Rescue Plan. So I would encourage you to look towards those dollars that the states can apply to get enhanced rates for mobile crisis, which a lot of these teams are mobile crisis teams. And so they could actually have Medicaid billing capabilities in a lot of jurisdictions too. And other sites actually, I think in Austin, you used a Medicaid waiver too at one point, 115 waiver to be able to actually support the work. So there are federal funding streams. There are also some federal grants, which you could consider applying to related to justice and mental health or related to substance use that might be able to help you develop a program as well. So just wanted to add that.
Yes, thank you all. And the next question I want to get to before we run out of time is from Toyin. Could you all speak to overcoming challenges regarding linking data among different data systems? So this is including those for behavioral health responders, traditional first responders, 911 call centers, law enforcement, and so forth, in terms of really linking data across different systems. And we've touched on this slightly. But I think it could be helpful to reiterate.
Okay, well, I can go. So for us, you know, you're part of one organization. I'm in the Fire Bureau. BOIC is our 911 call center, which is external to us. And of course, PPB is external to us, but we are all under the umbrella of a single organization. That said, we all are very siloed. And so some of our bureaus use Tableau. Some of our bureaus don't use Tableau. And so I think the one commonality that we actually all have is that we all have Excel. So if you can export your data into an Excel file, it's amazing what you can do. And the other thing too, I will say is the city has recognized that we are very siloed, and particularly around the public safety bureaus. And they've actually created a specific position for director of public safety to help unify and like get all of us to start working together. And so that is actually one of the goals, is to begin to have a single source public safety dashboard where the public could go and access all of this information in a one-stop shop. And so that is the direction that we're headed, but it's going to take a significant amount of coordination, and it will force us to really align which tools we're using as well. But it'll be a really good move for us. So it's challenging, but for right now, where we're at is we can at least export all of our data into an Excel file, and we can have conversations among each other and figure out a common tool that we want to use to upload that and create visualization.
Same with Austin. We're still in those conversations. There's a lot of legal issues related to that, specifically HIPAA, data sharing, things of that nature. So while we're able to more freely share with our EMS partners, because our healthcare law enforcement is a bit trickier. So we're still working through those challenges. And, you know, if anybody figures that out within their communities, please reach out so we can learn from what y'all are doing, because it is a huge barrier and challenge to get that information out, you know, as quickly as people are requesting it.
Yeah, there are a number of sites that we've seen locally around the country who are trying to develop shared behavioral health and justice databases where all data would be input in one place, and then you could only see certain things based upon, you know, the agency that you're from. So I think there are jurisdictions around the country who have started tackling this and who have had some success, but it's definitely a big challenge, and there has to be a lot of stakeholder buy-in to be able to get this executed. So I think starting the conversations early and often about why it's important, how it can help with a long-term continuum of care, and making sure that, you know, people are served in the community is just an important conversation to begin having as you're talking about this.
Yes, thank you all for your responses there. I also wanted to do a quick follow-up question for Robin specifically. There was an audience attendee who had asked for you to talk more about giving folks bus tokens for transportation and what that looks like when you had mentioned that earlier.
Yeah, so each of our community health workers actually have their own P card, corporate P card, and they're able to go and actually purchase what we call a hop pass. It's like a card, however many they need. to be able to meet the needs. And then it's really used upon discretion. So we don't actually have a set protocol in terms of what that looks like just yet. That might come as we scale up and expand our staff. That's a lot of, potential staff to have discretionary, decision making on P-card stuff. But right now our team is 1. So we have a team of 4, and it's working well. So we don't unfortunately get any sort of discount for being the government or being an agency or an organization. There's no business discount for us. So it's literally just going and buying like a $5 hop card and then distributing them as needed.
Thank you, Robin. Okay, I think we can fit one more question in. One question that had been posed is does any group have information on what primary age groups that alternative crisis teams are serving the most? So just looking at if there is a primary age group that is being served by your program.
Yes, we collect that data with our mobile teams. And it's different between our 2 teams. So the expanded MCOT team that receives referrals from first responders and calls diverted from the 911 call center, they're primarily seeing individuals in the age group of 18 to 45, are 2 highest age brackets that we see. For the team that is responding to calls received by our crisis helpline, our community helpline, they see about 3 times more children and adolescents than our expanded MCOT team does, which I think is great, that families know the least restrictive option of the helpline and aren't utilizing first responder services. And that team really focuses on building relationships with the school district. So that's helpful for their students in referring to the MCOT team or going through the helpline. But we have age brackets that we report on how many clients we get referred to per quarter and then for the whole year.
We do not track that. But I can tell you just from at least being on the field, that sounds about similar age group in terms of what we're seeing as well.
Thank you both. And I know we have about 4 minutes left, but I wanted to pose one final question, and I'll pose it to Sarah. And if anyone wants to add, please feel free to. Is anyone looking at, or is anyone aware of anyone looking at a correlation between the existence of an alternative response program and a reduction in police violence?
Yeah, so this is a good question, and correlation from a research perspective is always hard to prove, so that is difficult. I would also say that community responder programs are actually meant to take some of the burden off police in responding to this. So it's not actually about education towards police. There's police mental health collaboration program work, different types of trainings that police can do on de-escalation and use of force that can do that. But this is actually meant to create an alternative to law enforcement responses. So I think the correlation wouldn't be exact, because this is like, instead of having police respond, if someone's having a mental health or substance use crisis, or might be getting called because they're an unhoused person, this is actually sending someone besides law enforcement. So it's not directly related to law enforcement use of force. There's certainly literature on how to decrease some of that, which would include department policy changes and additional trainings that can happen. But I would say this is actually slightly different, and I'm not sure if you could show that correlation, since instead of sending law enforcement, you're sending this other team to the scene.
Yes, and I think honestly, this is a good way to conclude our discussion today, because when we think about data, when we think about what the purpose of these types of programs are across the spectrum, across the crisis continuum, it's important to realize that we really are saving lives when we create alternative response programs and when we create community responder programs for people who are experiencing crises, who might not respond to a law enforcement person in a specific way that, would be looked at as a good way to respond. Because when you're experiencing crisis, you often can do things that might be considered dangerous when you truly are just in need need of services and help. And so I'm really excited about everyone who was able to come today and to attend this webinar. Thank you so much for presenting your time and your energy and your attention. Thank you so much to the speakers. Thank you so much to Vital Strategies. Also, I want to just promote Taking the Call, our Taking the Call conference. I'm going to send that in the chat right now. Essentially, Taking the Call is a national virtual 2-day conference that will be occurring from October 20th to October 21st of this year. And it's with support from the Bureau of Justice Assistance, the Council of State Governments Justice Center, and then also the University of Cincinnati. And a central question that will receive attention during this conference is, how can we truly make improvements to our 911 and crisis response systems that support the needs of people in crisis to rebuild trust with communities and protect people? So you can register on our website at the link that is provided here. And yes, also, yes, please attend our Community Responder Program Toolkit launch on October 12th. More information will come. I do have all of your email addresses since you all registered, and we'll be sure to update you with resources, the slide deck from this presentation, and any other resources that Integral Care and Portland Street Response and our center, the Justice Center, provide. So thank you so much for taking out the time. And yes, we really do appreciate it.